Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClipWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with mouldy earwax. When I say mouldy, this patient has otomycosis, which is a fungal infection. And more specifically, they have Aspergillus niger, which is a strain fungi that is commonly actually found in the ear. Now, about 20 to 30% of outer ear infections, so otitis externa, are of a fungal origin. And out of the fungus ear infections, the majority, I would say about 70 or 80%, if I'm not mistaken, are due to one of several strains of Aspergillus. So you get Aspergillus niger, flavis, for example, and the remaining 20-30% are due to Candida. I actually think the percentage of otomycosis is probably more when compared to bacterial infection. So bacterial otitis externa is the most common type of outer ear infection, so they're of a bacterial nature. And as I mentioned, about 80 or 70% are bacterial. But I think fungal infections are probably misdiagnosed as being bacterial, and therefore the patients are then prescribed antibiotics, which then exacerbates their fungal infection, because antibiotics not only kill the pathogenic bacteria or inhibit its reproduction, but it also affects the healthy bacteria, which we all have in our ears. And in the absence of the healthy bacteria, resident fungal strains, the ones I listed before, they're given an opportunity to reproduce and exponentially grow because they don't have any competition. Sorry, I've got a bit of a cold at the moment, so I do apologise if I sound a bit bunged up. Now, when I remove this, you'll see the fungal spores, which is a landmark of Aspergillus. And you can sometimes see hyphae, which are these woolly strands. It wasn't much hyphae visible here. With Candida, it's a lot more like a thick, creamy consistency. It's harder to remove, actually. And if someone attends with a fungal infection, they don't necessarily experience ear pains or otalgia. That's more common with bacterial infections. And the main symptom of a fungal infection is itchiness and irritation, and kind of layers of dead skin. Sometimes it can be dry dead skin, sometimes it can be wet. So you get squams. When I mean squams of dead skin, the individual skin cells are still interconnected, and the skin hasn't fully shed, so it's still sitting on the canal wall. It's partially separating, and you'll see that here. So far we've used a combination of microsuction and the angled ear hook to get in and behind. This plug here, it's quite large and it's just trapped at the entrance. You can see it's just stuck here, so we're trying to wriggle this through. And normally earwax isn't black. You can get dark earwax that oxidizes, but this was literally pitch black. So it's coated in the fungal spores, and they are going to become more and more visible as we start to remove this. So I've just used the hook again just to prise this away. The consistency is getting a bit soft and mushy now, so the hook somewhat kind of cuts through it. It could have reached out for the correct, but I can feel it coming away now. And you can see some of the spores, they've settled on the canal wall. There's a few there. And here's a good view. So we've cleared the occlusion, but this patient's now got this layer of dead skin that I mentioned before. The eardrum is really healthy. Now we're going to start trying to peel some of the skin. You can see some of the fungal spores resting on this. Actually, as I entered, there were some fungal spores in the specular, which I've picked up there on the suction tip. So I'm just readjusting the focus now. I am going to use the zoom function in a moment. Very deep, right next to the eardrum, there's some fungal spores there. And just by zooming in, it made the job a bit easier. Now, I didn't remove every little last flake. It's not always possible. Got to consider patient comfort as well. But you'll see from where we are now, where you can't really see the canal wall, all of this we managed to take away. There was some squams of skin, as I mentioned. It wasn't fully shed. It wasn't ready to come away. So when you're peeling it, you can feel it's attached to the canal wall still. And then just going to... The entrance of this patient is quite narrow, so I managed to use the medium-sized specular to dilate the entrance. There's just some, as I said, fungal infected skin on the anterior canal wall here, so we're just going to delicately suction that away. So this patient's skin, as I mentioned, you can get kind of dry skin, or you can get kind of wettish squams, and this patient had more probably wetter squams. And that could be because of all the humidity created by the plug. It increases the temperature in the ear, so the skin gets damp. So you can see I'm just zooming in there. There's a bit of skin. That part of the ear canal is really, really narrow. I'm using the fine end, and this is the 18 gauge. I've also got a 19 gauge, which is even narrower, and a 17 gauge is becoming more popular. Using that more and more. But yes, very narrow medial aspect of the ear canal here. So I managed to get some of it away here, but then I'm going to revisit this near the end of the procedure. Some of it's tucked inside, embedded within the inferior recess. As we approach the eardrum, as you can see clearly, the ear canal narrows and it widens. And when it widens, it creates an opening on the left-hand side of the ear canal here, in the case of the left ear. We call that the anterior recess. And a little trench, a little basin, just in front of the eardrum. You can see the zoom works really, really well. Can really get up close and personal with this. Trying to peel it away. But the skin, it's just still strongly adhered. It's not coming away as easily as I was hoping. So I think I'm going to revisit that a bit later. I'm just going to start peeling a bit more skin away from the edge of the canal. So this patient's on antifungal ear drops now. With fungal infection, they are very hard to fully overcome. So some of the antifungal drop solutions in the UK, it's recommended use it for a fortnight, visit your doctor, make sure it's cleared, and once it's cleared, you use it for a further 2 weeks. Of course, if it's not cleared, you have to use it again and then revisit the GP. And the moment the fungal infection is cleared, it's always, well, at least with some of the drops, they recommend use it for a further 2 weeks, just to make sure there's no kind of fungal rebound, it doesn't remanifest. So a lot of the fungus in the ear, they live there naturally, they're natural residents of the ear canal. So the skin all around our body, really, it's got its own ecosystem. It's full of microorganisms residing on the surface. And in the case of the ear, we have bacterial and fungi. They coexist harmlessly when the conditions of the ear are what we call normal. So what I mean by normal, that they're not moist, damp, there's been no trauma, microabrasions, normal temperature, so there's not an increased heat, humidity in there, and the pH level is mildly acidic. Now, when the conditions change, so if you get water in the ear, for example, or you create microabrasions by poking and prodding in the ear, or you've visited a humid environment. So there's some of the things. It can then cause, in terms of the fungus, because that's what we're focusing on here, the natural strains of fungus that are already in the ear to exponentially reproduce and grow, and then that triggers your immune system. When your immune system is triggered, you get inflammation of the canal wall, and when you get inflammation of the canal, the ear produces more skin, and the more skin you produce, the more skin that is shedded, and it can collect, and then there's more of a food source for fungi. Some people can develop fungal infections secondary to eczema and psoriasis as well. I just revisited that bit there. I'm not going to get rid of that last speck. Some of the skin is just not wanting to come away, but the blockage is completely gone. I've got a good view of the eardrum. It's nice and healthy. So I'm just going to dilate open the ear canal again. You can see the back part of the eardrum. We're going to get the front part in focus now. There's the hammer bone, so that looks good. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.